to get this conversation started, Mehdi and I were talking. He and I are actually neighbors and friends, and we were talking last week about the paradigm for therapy for the SFA, and I think depending upon the clinical scenario, we worry about different endpoints. And for the claudicant, whether it's in the SFA or in any other distribution, we're looking at patency and quality of life outcome measures, whereas for CLI patients, we're thinking about limb salvage. But I think patency is an important component of how we approach the SFA in particular. And in fact, one of the reasons that SFA therapies are so vexing is that there's highly variable restenosis rates depending upon the therapeutic intervention that's selected, be it angioplasty, surgery, or other more advanced endovascular options. And so I'm going to show you a typical clinical trial type of patient, and hopefully we can get this to run. But this is a short segment chronic occlusion. I don't know if they can click that in the back. Let's see if we can get this to run. I don't know if there's anybody that can click the video for me. Otherwise, it's going to be a really short talk. In any case, this is a short, it's even shorter now. This is a typical short segment occlusion. I'll show you in a second. And what's important is that since the Schillinger paper in the New England Journal showing that PTA is inferior to stenting with respect to short and near-term patency, there's been a great deal of interest in the development of nitinol stenting for the SFA. And I think the baseline therapy of angioplasty alone is used very infrequently today as a primary durable therapeutic modality. And since this study was published now 10 years ago, stenting has become a dominant theme. And if one looks at a series of data sets, and this is just illustrative of what much of the data looks like, you can see that with respect to nitinol stenting, here's the resilient data, for example, with a typical laser-cut nitinol self-expanding stent. Most of the data look at freedom from TLR as the primary endpoint when looking at time points from 6 months out to 3 years. And you can see that with clinically driven TLR as the endpoint, stenting has been superior to angioplasty alone in study after study. Unfortunately, when looking at hard endpoints of patency, this is one of many illustrative studies that demonstrates that in real-world lesions, which are typically longer than 20 centimeters, you find that there is poor long-term patency, even with secondary interventions. And again, this is just illustrative of one of the most recent references I can find, but over the last decade, this curve has not changed very much. And in fact, there are a number of risk stratification schema that exist that demonstrate that if you have more risk factors, as documented on the right here, women with small vessels, diabetic patients, dialysis-dependent renal failure, those with critical limb ischemia, and those with long segment lesions and poor runoff, the patients that are typically afflicted by CLI, that long-term patency in these complex lesions that we treat every day are substantially worse than what's seen in clinical trials. And in fact, if I were to sort of summarize a lot of data in a single slide, this is adapted from Bruce Gray's editorial in CCI a few years ago, there's a linear relationship between lesion length and restenosis at 12 months, and you can see in the yellow arrow that angioplasty has a finite but quantifiable slope that clearly has a worse primary patency rate with lesion length. The slope of that curve, if you will, is flattened by the use of nitinol stenting, but it still doesn't have a completely flat or zero slope with respect to lesion length and restenosis. And so where we are in the field today with nitinol stents is the development of new designs. Dr. Zeller is involved in this particular new stent design, which is called the Mimics helical stent. In a preclinical model, you can see that by having this sort of helical array, the stent promotes swirling flow, which improves near-wall shear stress and reduces intimal hyperplasia. As you can see in the straight stent in the histopathology specimens on the top, there's increased intimal thickness versus in the helical stent on the bottom. And clinical data have been obtained for these patients, and the publication is pending. So in a typical patient, this is that patient that we couldn't see the video before. It's a relatively short segment occlusion that's about 8 to 10 centimeters, and this is the kind of patient that might be randomized in a clinical trial. And after balloon angioplasty, one gets a reasonable cosmetic result, But we know from the clinical data that this is not going to be a durable result. And so we have an alphabet soup of options for therapy. And so as the kickoff for this session, I think you can see that there are as many permutations for therapy as there are interventional therapists in the space. And so as we go through the lectures later today, you're going to see that there's an argument that can be made for all of these individual therapies. And there's very little in the way of comparative effectiveness data, which hopefully we'll get into in the discussion period subsequently. So if I were to summarize using the paradigm that I laid out previously, with angioplasty and nitinol stents, there remains a linear relationship and a finite but quantifiable slope that is characteristic of each therapy. So there's a steeper slope with angioplasty with respect to lesion length and restenosis. That slope is further flattened by nitinol stents, and I think is further flattened by the use of new technologies, be it novel bare metal nitinol stents or subsequent therapies that will be discussed later in this session. This is sort of a tabular representation of what I think primary patencies look like with the best available data. If you look at autogenous vein bypass, patency rates of 75% or thereabouts are what are quoted in the TASC guidelines. Prosthetic conduit has a much lower patency rate at 5 years. And all of the other therapies have variable rates of patency. And in fact, there's relatively poor data with most of these techniques, except for the drug-eluting stent, which has primary patency data out to 5 years. So, with respect to a paradigmatic approach to treating the SFA, this is completely made up out of my head, but this is how I approach it. And if you look at the third row down for nitinol stents, I generally restrict my use for nitinol stenting to short focal flow-limiting dissections when I'm using more advanced techniques for scaffolding and or drug delivery. So in this case, the patient that I showed was actually brought in for a drug-coated balloon clinical trial, was ineligible for reasons that I won't get into, and wound up getting a vascular mimetic implant, which Dr. Schmidt will discuss later, and this was his angiographic result. Now, he's fortunately still in my practice, and he's now patent 3.5 years later, but I think that we could have treated this lesion in a number of different ways, and I think that our speakers today will discuss their specific approaches for those sort of cupcake lesions. Unfortunately, what we treat most of the time is something that looks more like this. There's a patient I treated last week who has a 30-centimeter SFA occlusion with profunda disease, in which there was discussion about whether he should get surgical bypass and a profundoplasty versus an endovascular first approach. Crossing this lesion was fortunately not too difficult, and then after aggressive predilatation, this is what the angiographic appearance looked like. And so given that we thought we had a reasonable angiographic result without a lot of flow-limiting dissection, we did progressive drug-coated balloon therapy. And again, our drug-coated balloons come in a limited size matrix at this time. And this was after 3 drug-coated balloons were deployed in this patient's SFA. I hope Dr. Leiden's not here. But subsequently, this is what the angiogram looks like after drug-coated balloon angioplasty. And again, depending upon your perspective and the need for patency, as this was a claudican, I was a little bit unwilling to leave this result, and we wind up actually deploying supera stents, and this is our final angiogram. So I think this is the kind of strategy that many of us deploy, which is a stepwise approach, thinking about what is our cost effectiveness and what is our long-term patency, and I look forward to hearing from the other speakers today. So to summarize, the clinical trial suggests that there's reasonable near-term and mid-term patency and freedom from clinically driven TLR with nitinol stents. Real-world patients are more complex and have commensurately lower near-term and mid-term patency with nitinol stents alone, and the long-term data remain elusive, if not unlikely to ever be revealed. I think novel stent designs are likely to have some impact on long-term outcome, and combination therapy is likely to yield the best results, but I look forward to hearing from the other speakers. Thanks very much.
So hopefully I'm going to give you some new information today. DES versus DBE. You've heard this a bunch, right? Leave nothing behind. Maybe not. These are my financial disclosures. I was the co-PI for Cook-Zilver PTX. If you look at the variables that affect patency, so Hill did a great job of discussing this with you. I will tell you that I think the breaking point is 20 centimeters or longer, not this 15 centimeter, because if you look at the average lesion lengths, when people go, we looked at everything over 15 and it ends up being 17, which means they didn't look. When we look at ours and we say 20 centimeters or bigger, the average lesion length is 34. So you either have fairly short, medium lesions or you have really long lesions. Everybody excludes osteal from their trials, so we have no idea. Popliteal, still a discussion point. Calcification, even though they'll list severe calcification in their trials, nobody's doing real calcification. I'm sorry, it's not happening. It may be in Dirk Scheinert and Andre Schmidt's lab, but not in trials for approval of devices. They would never let you do that. Then there's technical issues, coagulation issues, technical issues. Just as surgeons have problems, we do too. And it's a whole other lecture, but I think we need to learn a lot more about that. And then as you heard, there's stents versus no stents, focal diffuse occlusions. Drug-eluting stents can do a lot of stuff for this. It pins up dissections, maybe an osteal disease, it treats recoil. It certainly increases MLD better than angioplasty. There can still be technical issues, and they have 5-year stable results. 5-year stable results. Nobody else has that. So whenever we talk about patencies, everybody else is talking what? 1, 2, and then Superior has 3, but nobody has 5. So why wouldn't you stent? There's a big thing of why won't you stent? Stent fracture. Well, how about if your stent doesn't fracture very much? Difficult to treat restenosis. Well, not all restenosis is the same. And you want to leave a surgical option. If you're stenting where they were going to bypass, you're a numbnuts, okay? Because you're supposed to stent where there's disease. Okay, Andre already showed you how not to propagate a dissection into a normal vessel, so you should not be doing that anymore. But you should not be putting stents in normal disease. And they don't bypass into disease. If they do, they're numbnut surgeons, okay? So you don't do that. But I think you have to remember a few things about the drug-eluting balloon trials as well. They did not demonstrate a class effect. The only successful PTA was in those trials. So if they didn't have a successful PTA, they were thrown out. Significant calcification is not in that trial. Don't believe anything you read. We had people during those trials sitting there going, that might be too much calcium. And that was mild to moderate calcium, okay? Nobody had severe. And it was only claudicants in the FemPop region. It was only claudicants, not CLI. Here's the first one. You guys, I won't even tell you which, well, I guess it already has on the slide. I was going to leave these blinded, but there's the first drug-coated balloon. Not a huge delta, you guys. Okay? That was a controlled trial, not a huge delta. And if you look at their primary efficacy endpoint at 24 months, significant difference, but not clinically that big a deal. That one's a little bit better. Those curves are a little bit more, I can eat them, right? Those are a little bit better. Now, as you've already seen, bare metal stents, if you look at short, long, and the longer they're in, they continue to decrease. Certainly length made a big difference. How about drug-coated balloons? Well, this is Impact Global's long lesion imaging cohort. And if you look at that at a year, in the lesions that were greater than 25 centimeters, you had a 63% patency rate. Now, TLR was not as big a deal. We need to understand that. But patency, if you just look at patency, and that's what we're aimed at, was not as good as we all make it out to be. And look at the number of provisional stents. If you look at the Impact SFA drug-coated balloon arm, 7.3%. Very low usage, very short lesions. You get a little bit longer in the overall Impact Global, 24% had stents in Europe, where they don't like to stent very much. And then if you look at the long lesion cohort, this was a drug-eluting balloon stent protocol because over 40% of the patients had stents. So you guys have to know that kind of stuff. And Andre actually, again, showed really cool stuff and saying the longer and long complex disease, years out, maybe we're not getting as good a result as we thought we were going to. So it's from optimal PTA, did not have significant calcification, did not demonstrate a class effect, did not have problematic lesions such as osteal disease. It was a drug-coated balloon with bare metal stent for paradigm for long lesions, decreasing effect, and the only critical limb ischemia data we have is problematic. So, is it okay to embolize a significant amount of mitosis-stopping medication where you need mitosis? I don't know, but I think as doctors, we need to know that answer. And just because we're 12 inches above the tibial, which did not look really great, that doesn't mean we should just willy-nilly be doing that. I think we need to look at some data on that. And I don't think we have good evidence that it works fine, versus a device with the longest term 5-year data with excellent results and low fracture rates in a varied population, including calcification. Well, we still need full metal jacket data. I don't think the stent is optimized for full metal jacket, but we need that data too. If you look at the 5-year data, you can see not only is it better than provisional bare metal stenting, the curves are continue to widen. In the European registry, at least at the 24 months, it seems to be generalizable to multiple different groups with long lesion sets, in-stent restenosis, et cetera. The Japan post-market study looked at almost 22% of the patients had critical limb ischemia, and they had a freedom from TLR rate of 91%, primary patency rate of 86.4%, so pretty reasonable in patients that had chronic kidney disease, critical limb ischemia, and diabetes. Whoops. We're encouraged, but we need much longer-term data for the Boston Scientific drug-eluting stent. We still just need longer-term data. Man, if that comes out in 2 years to be like that, we're hopping, because the stent fractures were low here too. This is the kind of stuff I want to show you. The first is a Zilver PTX full metal jacket that's occluded. Guess what that is on the right? That's me taking a catheter through the occluded stent and taking a picture. So there's a little bit of restenosis at the proximal and distal edge. The rest of it is wide open. We don't see that with bare metal stents. Something's weird. We need to understand a lot more of this stuff. We did look at the pattern of restenosis or drug-coated stents, and it looks like there's almost a 40% relative reduction in plaque burden in the Zilver PTX versus bare metal stents. And the nice thing is, guess what? Europe's doing another great, I love this trial, you guys. I really love this trial. It's called the Zilverpass trial. It's a first look at it, and it's DES versus venous bypass, the gold standard. And guess what's winning? Zilver PTX. Oh, that's got to have some people not sleeping well tonight. So what are the reasons not to stent? Stent fractures. Well, stent fracture rates have been really low. We need that data in full metal jackets, so with that caveat. Difficult to treat restenosis. This is mostly focal lesions. It's a lot easier to treat than that old bare metal stent restenosis. Leave a surgical option. Only numbnuts leave. Bad technique takes away surgical options. And it's beating the gold standard so far with 100 and some patients. And again, we talked about, whoops, I'm going backwards. Sorry about that. In the summary. So thank you for having me. I think it's cool data. I think it's a cool time. Thank you very much.
So as we've seen, we've got lots and lots of treatment options for the SFA. I'm going to obviously focus on covered stents. So hopefully in the next few minutes I can try to convince you of the point that long lesions and in-stent restenosis do represent, I think, 2 patient cohorts where covered stents still make a lot of sense. If we look at some of the early Viabahn data, there was a randomized trial of Viabahn versus prosthetic bypass. This was done by Dennis Gable's group in Plano, Texas. And basically, these were long lesion lengths over 25 centimeters, but if we look at these people out to 4 years, there was really no difference between the 2 groups. So certainly, at least for prosthetic bypass, this is a very good alternative therapy. Now, the Viper trial was a trial done here in the United States looking at the new and improved version of the Viabahn, namely with covalent heparin bonding and this proximal contoured edge to improve the flow dynamics between the native artery and the stent graft. This was a real-world lesion clinical study. These over 50% of the patients had total occlusions. Average lesion length was 19 centimeters, and almost 2/3 of the patients had moderate to severe calcification. If we look at the overall results, there was a 74% primary patency rate and 87 and 92% for assisted and secondary patency. However, when we went back and looked at the cohort from the core lab, one thing that was very interesting was the fact that if you did not oversize the stent by more than 20%, then you were rewarded with an 88% primary stenosis on the proximal end 87% on the distal end. So with this stent, like the Supera, technique is really, and sizing is of paramount importance. Dr. Zeller also led the way for the 25 centimeter Viabahn study group. These were for lesion lengths of greater than 20 centimeters. And the bottom line was this was a very high-risk patient cohort. Nearly 93% were totally occluded, and the average lesion length was very long at 26.5. And despite those adverse characteristics, a very respectable one-year primary patency rate of 67% and secondary patency rates of 97%. Well, the Viastar was really the first prospective randomized trial looking at Viabahn versus bare metal stent specifically for long lesions. And again, real-world patient cohort here, 19 centimeter average length, 80% CTOs, and task C and D lesion in nearly 3/4 of the patient cohort. And what you can see is a very dramatic difference in primary patency between the two groups, particularly for those lesion lengths that are more than 20 centimeters, where you see a 73% primary patency rate with the stent graft versus only 33% for the bare metal group. And if we look at the 2-year outcomes in terms of freedom from TLR, again, very dramatic differences between the two groups in favor of the stent graft. One of the things that people are always concerned about, of course, is, well, what happens if the stent graft goes down? What happens if it thromboses? Does that lead to acute limb ischemia? And in both the Viper trial and the Viastar trial, the answer is pretty much, well, no. Only one patient in each of those groups developed acute limb ischemia as a result of thrombosis of their stent graft. So putting it in perspective, looking at a number of other studies that have been presented to date, you can see that for these very long lesions, the covered stent group actually performs quite admirably for these long lesions in these complex SFA disease. Well, what about in-stent restenosis and stent fractures? This is obviously the Achilles heel of bare metal stenting and something that can be a very vexing and difficult problem to treat. So I'd like to just show a real-life case to sort of put it in perspective. This was a 62-year-old gentleman who came in with an acute coronary syndrome. We brought him to the cath lab, put a stent in his circumflex, but he was unable to do cardiac rehab because of severe claudication. Was subsequently found to have bilateral SFA, so we brought him to the lab for the first time in September of 2004. And typical, essentially flush occlusion, long occlusion of the SFA with reconstitution in the adductor canal. But luckily he had good 3-vessel runoff, and here we put a bunch of bare metal stents, got a very nice acute angiographic result. The problem was, over the next 2 years, he required 4 subsequent interventions because of recurrent in-stent restenosis. So the question is, what do we do for a patient like this? Well, again, a number of treatment options, which others will discuss in further detail today, but let me at least focus on the option of covered stents. The concept here is really pretty simple. Basically, the PTFE material acts as a physical barrier to prevent regrowth of tissue from neointimal hyperplasia. There have been a number of single-center studies looking at the use of covered stents, and the results have been very variable. We published our series back in 2012, where we had an 85% 1-year and an 81% 3-year primary patency rate with very long lesion lengths of about 24.5 centimeters. We did debulk in about 36%, but importantly, we very aggressively worked on having good laminar flow into and out of the graft, and specifically performed 25% inflow interventions and 39% of outflow interventions just to really optimize the flow through the graft. Now, the RELINE trial was a prospective multi-center randomized study done in Europe looking at Viabahn versus PTA. With average, the lesion lengths were between 4 and 27 centimeters. And again, real-world lesion lengths of about 19 centimeters. And if we look at the results, very dramatic differences between PTA and covered stents for ISR. Particularly when you go out to 2 years, only 12% of the PTA group were still patent at the end of 2 years. Importantly, there were no stent fractures appreciated at 12 months. And again, very dramatic differences between the two treatment groups. It's also important, I think, to remember that even though there may be restenosis with a covered stent, it's usually very short and very, very focal, and I would argue that that's a heck of a lot easier to treat than a Tosaka 3 where the restenosis, where the entire vessel is reoccluded again. It's critically important to follow these patients with close duplex surveillance. There are a number of technical issues that I really think are critically important. Avoiding oversizing is probably the most important, and it's really critical to treat all the disease and don't be overly obsessed about collaterals. And if you're going back and treating the proximal SFA, you really should go all the way back and treat the SFA ostium. Again, important to treat the inflow and outflow disease, and to be very, very vigilant about post-dilating and staying within the margins of the stent and not dilating outside the margins. I like to treat with dual antiplatelet for at least 12 months, and we perform very rigorous duplex surveillance. And even if the patient is asymptomatic, if they have a peak systolic velocity ratio of greater than 3 or a PSV of greater than 300 centimeters per second, we will bring all those patients back and treat them empirically. I would encourage you to read this article. Dr. Schmidt just recently published this. This is a great summary of the state of the art with drug-coated balloon using with a variety of different patient populations, including over a third who had in-stent restenosis. These were very long lesions, 24 centimeters. 65% were completely occluded. And again, because of the complex nature of these lesions, 23% received additional stents, 20% received outflow. And you can see that at 1 year, the results in terms of primary patency and TLR are really quite good, but there is significant and continued attrition of that primary patency rate between 12 and 24 months, and down to less than 54% at 2 years in terms of primary patency. So I think appropriately leading to the conclusion that DCB are safe and effective in delaying rather than preventing restenosis in these long, complex lesions and in restenotic lesions of the femoral popliteal tract. So remember my patient with the 4 interventions. We did bring him back and placed Viabonds with an excellent angiographic result, and he's been patent since 2006. So in summary, atherectomy, DCB, and bare metal stents and drug-eluting stents are effective for short to medium-length lesions, but the results for longer lesions are more modest with significant attrition over time. We have level 1 evidence that covered stents are superior to bare metal stents for long FMPOP disease and superior to balloon angioplasty for in-stent restenosis. And I think we'll see that drug-eluting stents, DCB, and anti-restenotic drug delivery will likely further improve the already very good results of covered stent for in-stent restenosis. Thank you.
This will be a talk about an interwoven stent, the Super stent, which we think really pushed the limits, especially for calcified lesions. I occasionally work here as a consultant for Abbott. So this is how the stent looks like. It's completely differently built than any other, let's call them standard nitinol stents, which are cut by a laser out of a nitinol tube. This one here is, interwoven with by stent struts and therefore completely differently built. As you can see, it has a very high flexibility and high compression resistance. You hardly can compress that stent with your fingers. And it's, so far as we noticed, absolutely fracture resistant. Therefore, we also think this is, could be a perfect stent in the popliteal artery area. It never kinks, and as I said, we never have observed here any fracture, especially also not in this region. Some more characteristics of the stent. It has, compared to the standard nitinol stents, no chronic outward force. This is simple to understand because you cannot oversize this stent once you implant it. It always has to size 1:1, whereas regular nitinol stents usually are oversized a little bit, 1 or 2 millimeters, and by that have a constant chronic outward force on the arterial wall. And this is maybe one of the reasons, this is one of the reasons which can trigger restenosis, which we obviously do not have here with the superior stent. And as I said, on the other hand, the crash resistive forces, so the forces against compression from outside is here with the superior stent much, much higher than compared to any other stent, 4 times higher or even a little bit more, making this device really a dedicated one for very calcified lesions. And this is what you can frequently see if you implant a regular nitinol stent into really heavily calcified arteries, that if you do different angulations with your angiography, that in one angulation it might look really compressed by the calcium even after good predilation. And if you manage to do some IVUS, you might see that the stent is completely flat. However, this cannot occur with the superior stent. Even in calcified lesions, it's always round and gives you a much better opening in these difficult lesions. It's important to understand how the stent works. So the deployment is clearly completely different. So you do not, as in a regular nitro stent, just pull back the outer shaft to release the stent. The stent is 3 times longer on the shaft than it should be later on once it's in the artery. So therefore, you actually have to actively push the stent out of the delivery system into the artery, and these 2 hooks here, which are connected here to this thumb drive, help by this. So with the thumb drive, you push these hook into the stent, and you push the stent out of the delivery system for several millimeters. Then you pull back here the thumb drive, and these hooks will hook again into the stent to bring some more millimeters out. And this means you pack the stent into the artery, and to be able to do this, it is very, very important to prepare the artery very accurately and thoroughly. And the size of the balloons which you use for predilation should clearly be not smaller than the stent you're intending to implant. For example, a 5.5 millimeter stent, so this is the outer diameter, you should at least use a 5 millimeter semi-compliant balloon, which you balloon up to until it has reached the diameter of 5.5 millimeter. This is usually near the burst pressure, or even maybe a little higher. And this clearly is important. Maybe you also use a bigger balloon at the end, a 6 millimeter balloon, in order to implant a 5.5 millimeter superior stent. And not the angiography after predilation is important to tell you whether you are now prepared for the implantation of the superior stent. It's rather the shape of the balloon. You shouldn't see any waist of the balloon. If you see a waist like this in a 5 millimeter balloon, you're clearly not well prepared for the implantation of a 5.5 millimeter superior. So you should continue with higher pressure, maybe with a shorter balloon, or maybe with a bigger balloon. So here, for example, we used a 6 millimeter balloon with very high pressure in order to implant a smaller balloon, a 5.5 millimeter superior. Still a little waste, but maybe acceptable. So easy to understand that in some cases, if it's very calcified, you may come close to a perforation. So usually we are also prepared to bring in a Viabahn then if you have a severe perforation. But I think Viabahns do not have the crash resistive force to overcome these recoil forces in such calcified lesions. So in these cases, we actually reline then the Viabahn with a superior stent. We do not have investigated these cases systematically, but we have the impression that it really gives us a very good patency doing this. So this kind of a case, long, extremely calcified, as Gary Anza said, this wouldn't be a case which would have included into many studies dealing with new devices for SFAs. This would be a clear case for a superior stent, especially if you see how problematic it was here to get the wire down and how it looks like after thorough predilation here with a 5 millimeter balloon with a nearly complete collapse here due to the calcium. As you've seen yesterday in the case, of course, in very calcified lesions, not the easiest thing to do to deploy the stent. So it needs some learning curve, but at the end, you can really achieve very, very nice results with the stents. And again, if you have an IVUS, it's really worthwhile to investigate this just to get the impression once here how nice these stents can be open. So we collected some data at our lab, and we are following this stent since it's available. Here are some patients which we collected until 2011, and you can see these were more than 500 legs treated here with the superior stent. And as you see, it's usually a stent not for the whole SFA, but we rather use it for the distal SFA and also for the popliteal artery. Distal SFA, this is the region where you have a lot of calcium, and that's where we usually use this stent. And this is our patency curve here of this stent here. We achieved here patency of more than 80% after 1 year and also 73% after 2 years. I think these are really quite good patency data. And what was very nice for us to see and surprising that actually if we implanted the stent into the popliteal area, which usually is an area with worse patency compared to the SFA, we had the completely the same patency. So again, this we think is a very good stent for that region as well. There are some other data, for example, from the SUPERB trial, multi-center trial from the US, 3-year data, but no patency data now. These are TLR data. And if you implanted the stent in a normal way, so appropriate implantation after the learning curve, then you can really achieve very good results compared also to other stents, which we know from other studies. Just briefly, here's a comparison which we recently did between other treatment modalities which we used in the past in our lab, like regular bare metal stents and also drug-coated balloons. We tried to rule out many differences between these groups in creating some propensity-matched cohorts. And it was really quite surprising to see what came out of this retrospective study. You see here a comparison between drug-coated balloons and bare metal stents, typical plateau which you can reach with bare metal stents. We did not so far see in more complex lesions with a drug-coated balloon. And this is the comparison between the superior stent and bare metal stents, where the superior clearly here was better. And this the comparison between superior and drug-coated balloon. Clearly retrospective data, and I would say it should rather seen as something which now should trigger some prospective trials to find out about the truth. But it really looks quite impressive what we found here. So to summarize, superior has really unique characteristics, very high compression resistive force, very low chronic outward force, very high fracture resistance. We think it's the solution for calcified lesions, especially in the popliteal artery. And the long-term results are really quite promising. Implantation indeed needs some experience. Thank you.
So obviously our goals with CLI are to treat ischemic rest pain and facilitate healing, lower levels of amputation, and facilitate healing of the amputation sites. And the question is, can drug-eluting balloons or drug-coated balloons improve the outcomes and achieve a better chance of succeeding in these goals? And here's a classic typical case of an 86-year-old woman who's got very complex disease and Rutherford category 4, and she's got this lesion here. And the question is, what would you do for this lesion to get an optimal long-term result? Occluded popliteal, before the drug-coated balloon, we had POBA, cutting balloon scoring, atherectomy, stent, the superior that you just heard about. We could bypass this lady. And what are the benefits and liabilities of each? I would submit to you that we don't really know what they are. And why would you treat with one thing versus the other? I don't know, but this is fortunately transitioning wrong. So we treated with we pre-treated and used a drug-coated balloon, 4 millimeter in the popliteal and 5 millimeter in the SFA, and she's gone out 6 months now. And the question is, would she have lasted longer if we used another therapy? Here it is right there. So I would argue to you that in spite of all you've heard today about the great outcomes that are now being achieved, drug-coated stents and drug-eluting stents and superior and so on, we still need therapy that achieves very durable patency by reducing restenosis. I think we're accruing more and more data in this regard, but there's still a lot of repeat interventions. There's still permanent implants, which may or may not be good. Gary Ansell's talk this morning was well heard, and so was Peter Sukas. I totally agree that these things are better and better and better, and don't fracture so much, and they give you good results. But they're not perfect. And will drug-coated balloons make a difference? I would say that the adoption of drug-coated balloons is a reflection of the desire on the behalf of American physicians since about a year ago, and European physicians since about 3 or 4 years ago, to have something different that they don't have to have permanently implanted. Obviously, there are technical considerations for and challenges for CLI, multi-level disease, heavy burden, diffuse nature of plaque that make it different than coronary artery disease. Calcified diabetic type vessels and aggressive restenosis. These are subsets where we have insufficient data on drug-coated balloon efficiency, but I would also say we have insufficient data overall. Well, how do these things work? In brief, it always amazed me that you could actually put a balloon in there with drug on it and get the drug to be absorbed even after you deflate the balloon or remove the balloon within a minute or two. But the way this works is that you deposit a reservoir of drug along the surface of the wall of the artery, or the inner surface of the artery, the endothelial surface, and it migrates over time into the deeper layers. And this is borrowed from Sahil, this slide that shows you there's different components to it. There's the drug-coated balloon itself, which has the drug and the excipient and the balloon and the way it's deposited and the way it's the materials layered on the balloon. And then there's the drug deposition and the drug clearance over time in the artery. And the ideal attributes of a drug-coated balloon would be one that facilitates the drug retention on the balloon during transit, but then deposits it effectively, adhering it to the wall of the artery optimally, and that the uptake of the drug is facilitated by the tissue. So as you all know, there are two approved drug-coated balloons in the United States. These are not approved for CLI. They're approved for use in the SFA and the popliteal in particular. Now, I guess if you have CLI on that basis, then you can use it for that. The indication was up to Rutherford Category 4, so they did include some patients with rest pain. There's the Levant 2 trial, which is the BARD device, and the Impacts SFA trial, which is the Medtronic device, and they both have real-world registries. This is the article we published in New England Journal last year, about 10 months ago, with the Lutonix balloon, which described the Levant 2 trial. Here it is right here, 2-to-1 randomization, and a pre-treatment. And amazingly, few patients came out of that trial. Most did not have bailout stenting. Most did not have diversion to the stent group, and most were kept in the trial. Of course, it was a limited subset of patients that fit the criteria for the trial, and you can see that there was actually a statistically different difference between the patency in the drug-coated balloon versus the standard balloon. And the same thing for Impact SFA, which demonstrated, again, even a more divergent difference between patency between control and drug-coated balloon, although there were slight differences in trial design, so it's hard to compare exactly. The remarkable thing about this was the lack of need for repeat intervention in Impact DCB, and I would tell you that the global trials of both of these devices have shown that they sort of have, the differences between them have sort of evened out, and the reality is they both have a biologic effect. They're both effective in reducing restenosis. Now the question is, are they as good as stents, and what about in CLI? And actually also, what about the long-term consequences? It looks like, based on some data from recently presented from Europe, that there may actually be a divergence, and drug-coated balloons may actually lose their panache after about 3 years. And the other point about this is that in the registries and in the trials themselves, there were very few patients with Rutherford Category 4 or 5 or 6. You can see 11% Category 4 and 4% Category 5, and that's in part because these patients were somewhat excluded. The 5s and 6s were, but even the 4s, they're very small numbers. So the question is, will these things translate across indications? Will they confer a benefit in the BTK application, and is CLI somehow different in these patients? And there are, as we know, challenges of intrapopliteal interventions that have to do with the diffuse disease, the calcific nature of these lesions, the length of these lesions, the small caliber vessels. And here's a example of how DCBs may not work as well in calcium, and it's possible that calcium represents a barrier to optimal drug absorption, one of those key factors that I described earlier. And of course, we know that calcium exists below the knee. So the early studies of PTA with below the knee using drug-coated balloon showed that there may actually be a benefit here. And Andre published one of the earliest one of these in 2010, showing that there was a benefit conferred by using drug-coated balloons compared to standard balloons. And in fact, Andre wrote up this initial experience with drug-coated balloons and below the knee with the Leipzig registry. And there were 109 limbs, and there was a definite improvement in restenosis at 3 months and at 12 months compared to the control patients. And these patients all had clinical improvement by and large and good wound healing in 74% and 96% limb salvage. Pretty darn good. The 16% mortality bespeaks the problem with these CLI patients in general. And when the restenosis occurred, importantly, it was focal restenosis, and that's what we see with drug-coated balloons. So they may prevent the large, you take a long lesion, you turn it into a short lesion, which is easier to treat on the rebound if it does restenose. The debate BTK trial, which was published a couple of years ago by Listro, again, showed that there was a demonstrable benefit for drug-coated balloon. You can see the curves diverge here compared to controls. So the key findings from this were that there was superior vessel patency and ulcer healing at 12 months, but no difference in amputation. But there was a remarkably low amputation rate in the PTA group. And this trial underscored the importance of good wound care because, quite frankly, that's what leads to a successful result. Well, what about the proverbial fly in the ointment? What about this trial? This is the Impact Deep trial, which actually showed that there was no difference between drug-coated balloon and PTA. And this is a little bit of a later trial. And the question is, why is this? There was a trend towards more complex wounds in the PTA group. The PTA group had longer lesions of DEB, and in spite of that, they did actually just as well. There was a trend toward more recurrence in the PTA group, so there was slightly that ended up in the DCB benefit. But there was also this question of a safety signal trend towards more amputation in the drug-coated balloon group, which I think, if you look at these complete data, show that there probably was, we're not really sure what to make of this, to be honest, but it does raise a question, and in fact, so much so that the FDA actually weighed in on it with their warning about this, or the agency in Europe. So why didn't it work with Impact Deep? PTA arm had a better efficacy, partially because the restenosis rate was very low in the PTA arm alone, and the amputation rate was very favorable, perhaps much better than expected. And the reality is that this is a multifactorial disease state, and a lot of things weigh in on this, and it's very complex to sort out what is the effect of a given treatment effect, a different treatment versus control. So one of the possibilities that I'll just mention briefly, and I'll wrap this up in a second, is that there might have been some differences in the balloons, and quite frankly, we don't know the exact drug doses that were delivered there. It is possible that there also might be some flaking of the debris that went downstream. We're not really sure. The bottom line is that we need to pay attention to these important issues. Runoff is important, so if you're putting a drug-coated balloon below the knee, you got to make sure that you maintain the runoff. I told you I'd do some work with Surmodics to developing a drug-coated balloon that has a little bit more uniform coating and delivers a little higher dose than other drug-coated balloons, but we're not sure if this will actually pan out. Bottom line is, this is from Thomas Zeller, who knows more about this subject than anybody on the planet, who said that a couple of years ago, currently there is no proof of a benefit for drug-coated balloon in CLI patients, and further research is needed. I would agree with that. The class effect of these balloons has been proven, and they appear to be safe, but we need more data. The costs are unknown. We definitely need much more comparative data. Thank you.